When evaluating the role of NAD precursors in cardiovascular health, niacin nicotinic acid stands alone with a therapeutic profile that neither NR nicotinamide riboside nor NMN nicotinamide mononucleotide has been able to replicate. While NR and NMN are often promoted for their capacity to raise NAD and enhance mitochondrial function, they fall short in an area where niacin has already proven itself: lipid modulation. Niacin's ability to lower LDL, low-density lipoprotein, raise HDL, high-density lipoprotein, and reduce triglycerides is not only well documented but also unique among all NAD precursors. This makes niacin a distinct therapeutic agent in cardiovascular and metabolic disease prevention, one that NR and NMN, for all their promise in cellular rejuvenation, simply cannot substitute. Niacin's impact on lipids is multifaceted. First, it decreases hepatic VLDL, very low-density lipoprotein, synthesis, which in turn reduces circulating LDL levels. Second, it inhibits adipose tissue lipolysis through GPR109A receptor activation, decreasing the flux of free fatty acids to the liver and thus limiting triglyceride synthesis. Third, and most importantly in the context of cardiovascular risk, niacin uniquely raises HDL cholesterol, an effect that no other NAD precursor, nor most lipid-lowering drugs can match. HDL plays a central role in reverse cholesterol transport, removing excess cholesterol from peripheral tissues and atherosclerotic plaques and returning it to the liver for excretion. Elevating HDL has long been considered a key strategy in reducing residual cardiovascular risk, particularly in patients already on statins. These effects are not theoretical. Clinical trials over several decades have confirmed that niacin can lower triglycerides by 20 to 50%, reduce LDL by 5 to 20%, and raise HDL by 15 to 35%. Though the role of HDL has been debated in recent years, especially in light of trials where HDL-raising drugs failed to reduce cardiovascular events, niacin's impact on multiple lipid fractions and inflammatory markers distinguishes it from purely HDL-targeted therapies. Its benefits extend beyond cholesterol numbers. Niacin improves endothelial function, stabilizes atherosclerotic plaques, and reduces oxidative stress. These pleiotropic effects reflect a deeper metabolic recalibration, not merely surface-level lipid adjustments. In contrast, NR and NMN have shown no consistent ability to improve lipid profiles in humans. While some animal studies have hinted at modest triglyceride reductions or improvements in hepatic steatosis, these findings have not translated reliably to clinical settings. Human trials of NR, even at doses up to 2,000 milligrams per day, have not demonstrated significant changes in LDL, HDL, or triglyceride levels. NMN's lipid-related effects remain mostly unexplored in human cohorts, with preliminary studies focusing more on glucose metabolism, insulin sensitivity, or vascular function. Moreover, neither compound interacts with the GPR109A receptor, the very target through which niacin exerts many of its cardiovascular and anti-inflammatory benefits. This lack of lipid modulation is not a minor gap. It represents a major limitation in chronic disease prevention. Dyslipidemia remains one of the central drivers of atherosclerosis, metabolic syndrome, and age-related vascular disease. A compound that can modulate lipids across multiple axes, while simultaneously supporting NAD levels, occupies a rare therapeutic niche, one that niacin alone fills. While NR and NMN may be valuable adjuncts for intracellular NAD restoration, they do not address the systemic dyslipidemia and metabolic overload that characterize modern chronic disease. It's also important to note the cost-benefit dimension. Niacin is widely available, inexpensive, and can be titrated to doses that achieve clinical lipid modification. Despite the flush, which can be mitigated with extended-release formulations or dose ramping, it remains an accessible and scalable intervention. NR and NMN, on the other hand, are expensive, less regulated, and lack the outcome-based data needed to justify their use in cardiovascular prevention. Until randomized controlled trials demonstrate otherwise, their utility in lipid modulation remains speculative at best. In conclusion, niacin offers a combination of NAD, repletion, and lipid control that remains unmatched by its designer derivatives. Its ability to lower LDL, raise HDL, and reduce triglycerides, while simultaneously improving endothelial function and reducing inflammation, makes it a cornerstone in cardiovascular prevention, especially for patients with complex lipid disorders or residual inflammatory risk. NR and NMN may play supporting roles in cellular energy and aging, but they cannot fill the therapeutic space niacin occupies in metabolic and vascular medicine. This is not just a matter of degree, it is a fundamental difference in pharmacological identity.